Hey guys, welcome back to the Skinny Truth Podcast, episode 6. I'm here with Dr. Josh Roller. I'm Laura Flusche, and we are so excited to be back this week with a topic that I think you guys are really going to like. We're going to talk about all of the different current available bariatric surgical options that are out there. We'll kind of touch on like the pros and cons and which surgery is right for which individuals. But as always, you can find our podcast on all major platforms, including Apple Podcasts, Spotify, and YouTube. And we would love it if you could rate, review, and subscribe. So let's get to it. You want to go first, Dr. Roller?
We'll start off by saying, or I'll say, there is not one right surgery for every patient, meaning it's not like everybody should get this or everybody should get that. And I just think in general, it comes down to the patient, their own medical history, their preferences, their medicines that they may or may not need to be on, their family history, like what could be coming down the road for them. Weaknesses, like are you sweet eaters? Are you volume eaters? That's how the process goes for matching somebody up. And I think a lot of people sometimes get into the trap of, well, I know somebody who had this surgery, therefore I want that surgery. And that's really not how we do this. It's an individual case-by-case basis. And there might be multiple surgeries that could be appropriate for a single person. So just let's start there, that there's not a single right surgery for every patient. Everyone is different. It is really important that when you're looking at this, that you do choose a program that offers all of the surgeries. I just operated on somebody from New York yesterday. And, she wanted the modified switch. It was not being offered. Now, fortunately for her, she knew that the modified switch was even an option because so many patients, how many have you seen on your Instagram channel that said, hold on, what's the modified duodenal switch? I've never even heard of this.
Yeah, so many people. They're like, I've never heard of this. I wish I would have known that was an option when I had my surgery.
That's so important to do your research, as there are all of these different options. Find a place that offers all the different options, because let's just say they don't offer, if someone doesn't do a gastric bypass, then you're not going to get that choice. And what if that's the right surgery for you? And that's the thing. You don't want to be limited by geography or surgical program or surgeon's capability, anything like that. You want to have the availability to choose what is going to be the best for you in the long term.
Right. Kind of a non-biased opinion of what's really right for you.
That's right. I do them all. So, I want the best outcome for the patient. And from a pure, being a doctor, being a surgeon, I'll tell people all the time, I don't care how much weight you've lost in 6 months. What I care about is how much you've lost in 6 years. Because I don't want you to have to do it again. And I guess that's another important point. There are two philosophies kind of in bariatric surgery, and I'll tell you mine here in a second. But one is obesity is a chronic disease and it will never go away. And therefore, it doesn't matter what surgery you do, you're going to need a revision a few years down the road. I hate that philosophy. I hate that philosophy because I do think it could be treated in one surgery. And I think, we said it 1,000 times, it's a tool. If the patient uses it correctly, it will last a lifetime. So my philosophy is do the best, most powerful surgery the first time so the patient never has to come back for a revision. We don't want to do revisions. We want it to be, we want that surgery to last because it's tough enough to make the decision the first time to have surgery. But now you got to make it twice. And I think it's even sometimes more difficult of a decision to make for patients because they're like, I failed this operation. Why would the next one work? And here's the honest truth. Just because one surgery doesn't work doesn't mean the next one won't. You have to ask yourself, did I get the best surgery for me at that time? Like the most perfect example is the lap band. When I started in 2007 practice after my fellowship at Duke, and 99% of patients came in wanting a lap band. And then, gosh, it's probably been about 10 years now. So all of a sudden in like 2012, 2013, finally all the data that we knew, the lap bands don't work. And at the 12-year mark, 51% of patients had to have their bands removed for complications, erosion, slippages. so people will come in and like, well, why will this work? The band didn't. Well, because the band was a bad operation. It was a bad operation done to lots of people. However, there are, and even with the band, as much as I didn't like it, there are still patients who are very suitable candidates for that operation. So it just really depends. But it subsequently just pretty much died and went away. And now it's less than 1% of all surgeries. So
oh, wow.
That was kind of the first surgery that was a big one as I was starting. And you had to have lots of real conversations about the weight loss isn't very good. The maintenance is super high. Remember that when you're seeking a revision, that it really depends on what surgery did you have? Was it appropriate at the time? Was it done correctly? I have done revisions on gastric bypasses, a gastric bypass. And then you get in there and they only bypass like 25 centimeters instead of 150 centimeters.
Wow.
So it was like they never had a bypass to begin with. But for the last 10 years, they've thought to themselves, oh my gosh, I failed this surgery. I can't have another one because it's not going to work. And I even had a gastric bypass. It's like, well, okay. And that patient was so relieved. I mean, you can't even imagine how relieved they were when I said, listen, you didn't get like a real gastric bypass. You got like a quarter of one. So this isn't your fault. All of those come into play when you're looking at procedures, now and down the road. So just because you had one doesn't mean that's it, that it's over, and that something else won't work.
Right.
I think we touched on the lap band. Less than 1% of surgeries literally worked by just helping you eat less. And it basically was like a roadblock. So went around the top of your stomach, food goes down, hits the band, stops. And literally a roadblock. And basically what we saw is a lot of people vomiting all the time.
That's what I was going to say. Yeah.
Yeah. Acid reflux can be bad. Lots of different complications from it. But ultimately, at the end of the day, the weight loss just wasn't as good. And a lot of people had to have their bands removed for non-tolerating it. And just to get to the big subject here, there's two different types of surgery. Restriction, meaning it limits how much you eat, and malabsorption, meaning you don't absorb as many calories. The band only worked by restriction, limiting how much you eat. And you look at the entire history of weight loss surgery, there's not been a very good surgery as far as weight loss goes when that's the only way it works. You combine restriction, not eating as much, and malabsorption, not absorbing as many calories. Those have been the most successful surgeries long term. So that was the problem. It only works by one method. So if you're a lower BMI, you didn't have as much weight to lose, you were a volume eater, meaning you would eat a lot but not as sweets, maybe the band was a good idea back in the time, but it's pretty much gone away.
Do you want to start with the balloon first?
Sure. This is what I would call a procedure as opposed to a surgery because we're not making any incisions. But we basically put it in endoscopically. So you're sedated and it goes down your mouth and down your esophagus and your stomach. And we put something that's about the size of a grapefruit, a bigger grapefruit, and it sits in your stomach. So what it does is when you eat, you feel full faster because you already have that volume sitting there. So it only works by feeling full faster. You leave it in for 6 months, then it has to come out, which again is taken out endoscopically. So no cutting, just a procedure down the throat. And, I've had patients do great with this. 3 things happen with a balloon. You lose the weight and you keep it off. You don't lose the weight, or you lose the weight and put it back on. So it really is kind of a fork in the road procedure in that there's some people who just can't wrap their mind around that they need surgery right now. This is a really good option because you can say, okay, this is my one last try. I'm going to do something, but it's not surgery yet. And let's just see what happens. And one of those 3 things will happen. If it works, then great.
I have a question. Can you reinsert that at 6 months or does it have to stay out?
No, I've got a patient I put in a balloon 3 different times. They do not want surgery. He loses the weight. He gradually puts it back on. Then we do another balloon. I will say the weight loss is not near as good as the other ones. We usually quote about 25% of your excess weight. So 100 pounds overweight, on average, you can lose 25%. I've seen somebody lose 90. I've seen somebody put weight back on.
Okay.
Or not lose weight, but gain weight. I think the biggest thing about that one is that the balloon is going to come out. It can come out. And so it's just doesn't have that permanent feeling the way the other surgeries do. Good surgery for those that need to lose 15, 20, 30 pounds. And especially don't want to take the medicines and experience the side effects of those. So good operation, but not for everyone.
Yeah. And I feel like that one's less known too. I don't know much about that one. So
it is, and it's not no insurance covers it. It was FDA approved though years ago, so it was not covered by any insurance. So if you have to cash pay, I mean, it's definitely cheaper. It's about half the price of the other surgeries.
Yeah.
But it's also a 6-month tool as opposed to a lifelong permanent tool. Right.
Yeah. All right. Well, then let's start with probably, I feel like one of the most common bariatric surgeries that people know about is the sleeve gastrectomy, also known as VSG. You want to dive into that one?
Yeah. So this operation, and not many people know this, the sleeve actually came from the duodenal switch. That is how it started. And basically it was when you remove the bigger part of the stomach, and then you did all the rerouting for the duodenal switch. And people were doing, at that point, they were doing duodenal switches on really big patients, 500, 600, 700 pounds. It was really hard to do laparoscopically. So they would then remove part of the stomach, which is now known as the sleeve, let them lose 100 pounds, then bring them back in 3, 4, 5, 6 months and finish the surgery. So it really was never intended to be done by itself. It was always part of the duodenal switch. And it wasn't even called a sleeve at that point. And with time, people realized, hey, maybe this could be an operation for a single stage. Maybe this is the only part that they need. The sleeve, in my opinion, is just a restrictive only procedure, meaning it only limits how much you eat. It's a much bigger stomach than like the pouch in a gastric bypass. There's no malabsorption, so you're going to absorb every calorie that you eat. I really like sleeves in situations like lower BMI individuals that can still exercise and don't have all the joint pain. Those I think can be a very good candidate, or if somebody's had a real extensive surgical history where they've been opened up and mesh, and then maybe a sleeve is a good option in that point. The weight loss in our experience is significantly less than the other operations that include malabsorption. And what I tell patients is you just have to be much more strict with this surgery. You don't get the benefit of not absorbing every calorie that you eat, because with a sleeve, you will absorb every calorie that you eat. So when we're all human, I mean, you're going to have days where you make a bad choice and eat something you shouldn't. I mean, with the other surgeries, you get the benefit of, okay, I messed up, I'm human. With the sleeve, you kind of pay the ultimate price and you absorb all of those calories. So benefits are that there really is not any risk of malnutrition or malabsorption. Some people argue there are some metabolic effects because there are some hormones that are made by a portion of the stomach that's removed called ghrelin. It's one of the hunger hormones that goes way down. The thing, though, about our bodies is that when you take away one hormone, another 10 will jump in and take its spot. And the best example I give is a kidney. If you were to take out somebody's kidney, the other one will work twice as hard. And, I had this discussion with patients. I'm like, can you make the kidney not work twice as hard? Can you stop it from doing that? And the answer is no. Our bodies are meant to compensate. So when you take out one hormone, there's a lot. And so that's what you see with the medicines. They're trying to take out, 1 or 2 or 3 different hormones. We really don't know what the long-term effects of it's going to be and what else is going to come. And because our bodies are just not meant to do that. You take out a section of colon. What does the rest of the colon do? It works harder to make up for what that one piece is doing. So sleeves, the most common surgery out there. A lot of the philosophy behind it is obesity is a chronic disease. It's never going to go away. Sleeve is the easiest one to revise. In fact, for revisional surgeries, that's the one we see the most now. 5 years ago, it was always lap band to something. Now it's sleeve, either to sleeve to gastric bypass or sleeve to duodenal switch. There's studies out there that show the reflux can be pretty bad with the sleeve gastrectomy. And so somebody that has acid reflux, I definitely stay away from sleeves in this situation. There's something called Barrett's esophagus, which can be a precursor to esophageal cancer. And there are studies that say, yes, that rates of Barrett's esophagus goes up. Some that say it doesn't. Nevertheless, we recommend monitoring for that. So if I were to boil it down, though, just to making it extremely simple for people to understand, is like the lap band, this limits how much you eat, and that's it. It's just doing it in a different way. And the history of weight loss surgery, there are lots of different ways to staple a stomach to make it smaller, but none of them have ever worked as well or long-term compared to the other malabsorption surgeries.
All right. So with the sleeve, what can patients expect percentage-wise of their excess weight to lose?
So what we tell our patients in our practice is somewhere between 40 to 50%. And other people will quote higher, but that's our very realistic expectations with that surgery, given its kind of lack of power. Obviously, some people can lose more, and there's some people who lose less. So, but that's what, so if you're 100 pounds overweight, we'll tell people 40 to 50 pounds. And then ask them, are you okay with that? Is that your goal? Most of them are like, no, I want to lose more.
All right, so let's go to the next one, the gastric bypass, Roux-en-Y gastric bypass. We'll talk about that one.
So this is one of those combo procedures of restriction, limits how much you eat so you feel full faster, and malabsorption so you don't absorb as many calories. First done in like 1967. Of course, it was open and, lots of time in the hospital. Complication rate's pretty high. We've gotten really good at that just in general as a bariatric surgery community. It's been done a long time, all laparoscopic now. So it's a really good operation. It works. I tell people somewhere between 70 to 80% of your excess weight can be lost. You make a small pouch about the size of a large egg. So you think about 4 ounces of chicken, 4 ounces of meat, and you should be done eating. So you'll eat a lot less. It has something called dumping syndrome that happens. It's not what people think it is. It's not what it sounds like. What it's referring to is with your pouch hooked up to your intestine, food, because there's no valves, food dumps into the small intestine. If you eat something high in sugar, all of a sudden all that, instead of that food and sugar slowly being released into your intestine like it is normally, the food dumps. Now the pancreas says, oh my gosh, the sugar is real high, so it makes all this insulin. And that insulin starts to drop your blood sugar, and then you get lightheaded, nausea, dizziness, facial flushing, abdominal pain, and you'll think your world is going to come to an end for 30 minutes to an hour. But it's because you ate something really high in sugar. Sometimes it's a chocolate cake. Sometimes it's just because you're at a restaurant and you ordered unsweet iced tea that you put sweet and low in. But when that person comes around to fill your tea up, they poured it full of sweet tea. So I used to instruct all my patients that had bypass, like, only get stuff with lids on it so you know what it is. But in general, that dumping syndrome, I think, is actually a good thing. It is your body's internal way of slapping you on the hand going, do not make that food choice. Women usually do it once. Men, it may take them 2 or 3 times to figure out that it's a bad move. So that's how it works. One day in the hospital, go home, liquid diet for 2 weeks. And the downside, so the weight loss is really good. The downsides to the bypass are a couple. One, you can no longer take NSAIDs. That's ibuprofen, Motrin, Aleve, you can't take aspirin or steroids for the rest of your life because it can create an ulcer at the pouch where it's connected to the intestine. And so that's a real Achilles heel because maybe, you need Motrin or ibuprofen for migraines, or maybe you have bad knees and a bad back. And so that was a real issue when I was only doing gastric bypasses. You would hope that the weight loss would take care of the joint pain, but maybe not. But then maybe what about real life situations? You've lost the weight, you're out playing soccer with your kids and you twist your ankle. Well, normally all you do is take ibuprofen and ice and rest for a week and you're back. But with a gastric bypass, you cannot. Or you go camping, you've lost the weight, you're healthy, you're going camping with your family, and you happen to get into a bunch of poison ivy and it's everywhere. And there probably is not a worse thing in the world than uncontrollable itching.
Oh my gosh.
The
worst.
Drive you insane. I remember when I had my back surgery, they went through the front to get to the back, and that was my first insight into surgical glue and suture. And it's almost like having chiggers. It's just awful. But you would treat that with steroids. Now you can't have that. And so I think that's a downside. You can get the ulcers that can happen at the connection between the pouch and the intestine. Those are very real and they do happen. It's on the order of somewhere between 1% to 5%. So it's not very many, but they can perforate, they can bleed, they can cause chronic pain. If you're a smoker or history of smoking, and you go back to it, nicotine it's the most common reason to get an ulcer is from smoking. And if there's no wiggle room to have a weak moment because it can be one cigarette or it could be a pack. It doesn't matter. So, and then something called an internal hernia. And because of the rerouting, so here's your pouch and here's the intestine coming up to it. Well, there's a space created here now that we sew down, but we're sewing fat to fat. And as you lose weight, that fat goes away, the space opens up, and now other intestine can get in there and get trapped. It could be fixed surgically, but it's a surgical emergency. And so those are the downsides to a bypass. I did a lot of these for the first 8 years of my practice. This is because it was this of the sleeve, and the weight loss is better is way better. So, and I think it's more of it's an easier to use tool because again, limits how much you eat. You don't absorb as many calories. And then you have to also look at the kind of malabsorption and that you can get vitamin deficiencies and different things if you decide I'm not going to take my vitamins and I'm never going to go back and get my labs checked. And that's usually what you'll see, on social media is Pat getting another iron infusion. Those kind of things, you're like, well, how did you get to where you went from okay to iron infusion? What were the steps along the way? And a lot of times it's just no follow up.
Yeah.
And not always on the patient. Maybe they moved, couldn't find somebody, whatever.
Right.
But that's another thing you do have to take into consideration with that. Generally speaking, malnutrition is avoidable. Just take your supplements, go get your levels checked, at least yearly.
Yeah, and you'll be good. What's the long-term success with gastric bypass?
Well,
is it pretty high still?
Yeah, it's like 65, 70%. Patients keep their weight off at the 14-year mark. So it's really good. And everybody knows somebody who's put their weight back on. You just don't ever count somebody that had a gastric bypass 14 years ago and hasn't put their weight back on.
Hasn't put it
right.
on. Yeah.
Those ones that do are the ones that set in people's mind, and you kind of focus on those versus the ones that have done great.
For sure. Yeah. Okay, so the last one that we're going to talk about, well, I guess there's two sections of this surgery, but the surgery that I had, the modified duodenal switch, also known as SIPS, SADI. I feel like all surgeons call it different things.
Loop, a loop bypass. I mean, there are lots of different names to it. It's the same surgery. It's the exact same surgery. SIPS, SADI. A lot of people call it SADI now. I call it the modified duodenal switch. I think we probably coined that term 8 years ago when I started doing it. And the original duodenal switch, I mean, there's some variations of it, but I think most people will say it was started by a surgeon named Hess and probably done like 1986 is where it started. And the downside to what I refer to as the original duodenal switch is the fact that they bypass like 95% of your intestine. What we call the common channel, or how much intestine you had left to absorb everything, was only 50 centimeters. Whereas in the modified, it's 300. So that was such a small amount that the complication rates were always so much higher with the duodenal switch that really no surgeons wanted to do it. I mean, we're talking complication rates, into the 30s.
Wow.
And yes, the weight loss was great, but at what expense? Liver failure, kidney failure, brittle bone disease, all these different horrible vitamin deficiencies. And, to their credit, they were also doing it on really big people. They thought they needed to be very aggressive with the surgery, and the weight loss was good. And like with everything, we learn and get better. So that was why the original never really caught on. It was always like 0.1% of all bariatric surgeries performed. Then you add in the fact it is technically challenging to perform, does take a little bit longer. So then the modification came, actually started with a guy named Torres in South America, and instead of 50 centimeters, it gradually backed it up like 200, 250. And then a couple of surgeons here in the US backed it up to 300. And that's when they called it the SIPS procedure. But two different modifications happened. One minor modification, one major modification. In my opinion, the minor modification was instead of 2 connections, they made it 1. We do connections all the time in weight loss surgery, so I don't necessarily look at that as like a big deal. Is there increased risk with a second connection? Maybe technically on paper, but in general, not really. But the major modification was this bypassing 95% of your intestine to 50%. So now all of a sudden you had a lot more intestine, and all those nutritional complications and protein deficiencies went almost away entirely. Horrible diarrhea that you saw with the original, the idea like it's running through me was real because they hooked it up so far downstream, it really was. So that's why I never caught on. In fact, I remember being a fellow at Duke going, I will never do that operation. What in the world? The picture looks insane. You read about all the complications. I'm a surgeon. I don't want to get into all of these metabolic diseases that we've created so then I took a real hard look at this 8-9 years ago, and I was like, these modifications make a ton of sense, and the weight loss is still awesome. In fact, it's better than the bypass. So I told people somewhere between 80 to 95% of your excess weight you can lose. But now we're not seeing all these malnutrition complications from bypassing so much intestine. There are a lot less. And so we've eliminated that Achilles heel. Then you add in the fact, the biggest thing for me was patients can now take NSAIDs and steroids. So for my older patients with bad backs and knees, that or arthritis in their hands, no matter how much weight you lose, that's not getting better with weight loss.
Right.
You can take your medicines.
Yeah.
And what if you're 25 and you need, you have a strong family history of rheumatoid arthritis and lupus and things that you need in like NSAIDs and steroids for, or you might need them.
Yeah.
To do a bypass
you don't know
on you.
What's going to come down the road.
You have no idea. You have no idea. Or maybe you just sprain your ankle or get into poison ivy. Maybe it's something simple, like that. Because I think we've seen 1 or maybe 2 ulcers in 8.5 years of doing this. And those were both in super heavy smokers that started back after surgery. So, that's the other thing about the modified switch or duodenal switch in general is you really don't have to worry about ulcers. You can take those medicines. We've only seen two ulcers in 8.5 years we've been doing it. And those were both in super heavy smokers that started back after surgery. And they probably would have had ulcers smoking that much even without the surgery. So we really don't see internal hernias with the modified duodenal switch. You can see those some, not as much as a bypass in the 2-connection duodenal switch, but I think the modified switch has been an absolute game changer. I went from doing about 95% gastric bypass to now about 95% duodenal switch. It is just that important to lose the extra weight, be able to take the medicines that you need to take without worrying about getting ulcers. It's the least chance of weight regain. And I think it's just the most forgiving of the surgeries, meaning you can be human, have a bad day, and it's not going to put 5 pounds on. I think if you continue to have those days, it could. But I just, for someone who said, I've said, a lot of times I'll never say never ever again, because I was never going to marry a doctor. I did. I now have 3 daughters, which that was not supposed to happen. And I'm doing the duodenal switch all the time. I said I would never do it. Technically a harder surgery to do. So I do think that's why you don't see a lot of surgeons having adopt this. It's, I think, the perfect revision for a sleeve. Unless you're having horrible reflux, then I like to convert that to a gastric bypass. So it really depends on why you need the revision from a sleeve. Horrible acid reflux, weight regain, never lost the weight, we go switch. Reflux, we go bypass. But it really has just been a real game changer for lots of different reasons. I even like it in adolescents now. Because of the medication issue. When a 16-year-old or 18-year-old, you don't know what's coming. You don't know what's coming, and you don't want to burn those bridges. And that's the best part about the duodenal switch. But ultimately, at the end of the day, it loses the most weight. The patients are the happiest. We can do now 500 and 600 pound individuals a whole lot easier than we could when it was just a bypass, and those because it was hard to get intestine up to a small pouch. So we love it. Obviously, look at you. It works.
I love it. I sing its praises every single day. Is the weight loss the same expected as the bypass? Is it 80 to 90 for the switch too?
So I'll say 70 to 80 for the bypass and about 80 to 95% for the duodenal switch.
Okay.
It's more.
Okay.
It is.
I've lost over 100%. So
yes, and there's a lot, and that's why it's higher, because we have a lot of people who've gotten to that 100% of your excess weight loss. And just, you remember some of the photo shoots we did. We got guys who've lost 300 pounds. We have a couple people who lost 400 pounds.
It's incredible.
And I've never had that happen with the gastric bypass. In 8.5 years of doing it, I never had it. I had people lose in the 200s, and I love the gastric bypass.
Do they absorb more? Is that the reason?
No. Well, you don't bypass as much intestine in the gastric bypass as the switch, but you also make a much smaller stomach with the gastric bypass. So the idea is, you're eating less, so you shouldn't bypass as much.
Yeah.
With a switch, you have a bigger stomach, so you need to bypass more. So the idea is that they end up equal, but it's probably not. The switch definitely is a more powerful surgery, no doubt about it.
So in the end, probably the malabsorption comes into play more than the restriction.
I think a lot of it, I think it's all of it. And I think the one thing that we haven't even touched on is the fact that the pylorus, or that valve at the end of the stomach, we keep intact with the duodenal switch, which you don't with the bypass. And I think that plays some effect that we're not fully aware of yet. But, it's not a new procedure. The modified's probably been around, or SADE, SIPS, whatever you want to call it, for 16, 17, 18 years now. We've been doing it for 8.5, 9. It just, I'm probably myself doing 15 to 20 of these a week at this point. And,
wow.
the amount of time in the hospital is the exact same. Incisions are the exact same. Our pathways and protocols after surgery are the exact same as a bypass, with the one exception of the multivitamin has extra vitamin A, D, E, and K in it. You still need to get your labs checked. You still got to take your supplements. All that is still really important. You can't not do that. So again, if I'm just summarizing, there's not one right surgery for every patient. And just like for you, the modified switch was great. Your husband, whose BMI was 35 at the time and diabetic, turned out that was the one best surgery for him. But we didn't pick that surgery because you had the modified switch. It was because it was the best choice for him. And I didn't even mention this, it's the most effective against diabetes. It is the most effective.
That's a big one.
So for diabetics, I really encourage the duodenal switch procedure just across the board. So, but other than that, you got to find somewhere where you have the options, do your research. I do have an app out there called the Weight Loss Surgery Selector. You can download it free it's completely free, doesn't cost a thing, but go to the App Store, download it. And what it does is kind of what we did here. You just go through your history and your family history and answer these questions, and it will spit out a preferred procedure and then give you a link to go research it. So I think it's so important. This is why I love bariatric surgery patients. Almost all of them have done the research, and they're able to have these conversations with you that you don't have with like gallbladders and hernias and things. You can get into the finer details of surgery and outcomes and expectations, so do the app, because that's a good starting point for answering these kind of questions and what surgery might be right. Then you can go in, and if your surgeon doesn't do this procedure, then you think it's the best for you, then go find one that does, and then ask those questions, and then go back and weigh your choices of,
right.
It's very much like in plastic surgery where, okay, I like this surgeon, but they're saying different things. It just comes down to your gut and making a good decision, an informed decision. And then once you're informed, you make your call, just get it done and go lose the weight and get healthy.
Yeah, for sure. So at the end of the day, and I always say that too when people reach out to me, make sure you go to somebody that performs all of the procedures, or talk to someone at least. And then, like you said, make an informed decision.
Because ultimately what will happen is if you go in and you ask for the duodenal switch and they don't do it, very few, if I'm just going to be blunt about it, they're not going to say, hey, you know what? I think that's a great option, probably your best option. Go see this person over here that does that, because I don't do it.
Right.
No way. They don't, that does not happen, unfortunately.
They want you to stay with them.
Yep.
And do the surgery that they perform. So
exactly.
Yeah.
But that's it. That's the 4 or 5 procedures that are out there between the band, the balloon, the bypass, the sleeve, and the duodenal switch. Pros and cons. Lots of information on the internet. I know we have it on our website at rollerweightloss.com, where you can look at the different procedures. Try the app. It takes about 5 minutes. Gives you at least a starting point. So hopefully this helps all the viewers. And I'd like to say thank you for everybody that's tuning in. All the really nice comments, and people are now coming into their pre-ops going, when's the next episode coming out? Or do you know Laura? I'm like, yeah, I know Laura. So you're famous.
Yeah, somebody just messaged me the other day. She just had a revision and said that she was talking to you about the podcast. So
yeah,
I love it.
It's been really good. So anyway, if you have, we appreciate everyone listening. If you would like, subscribe, download, follow us on all the different versions that are out there on YouTube and Spotify and the Apple Podcast. We'd really appreciate that, and we'll keep commenting and give us topics.
Yep.
We'll keep hitting on them. Otherwise, thank you for joining us.
Yeah, we'll see you next week, guys.